Hello, I'm going to discuss with you a very important topic, Candida sepsis, how to improve the outcome. Generally, Candida sepsis we see at two sides. One is in case of the bloodstream infection, especially the sepsis which has been there, or you can see also abdominal sepsis or a particular organ like pancreatitis, cholecystitis, peritonitis. In case of the bloodstream infection, our success rate in case of diagnosis is around 50 to 70%, whereas in case of this abdominal infection, the success is very poor because bloodstream infection, because blood culture positivity rate is very low, less than 15%. So you need to have surgery and get specimen directly from the tissue for diagnosis. So to overcome this barrier and to have a better outcome, you need to resolve certain dilemmas. First dilemma is whether the sepsis is of bacterial origin or fungal origin. That is for diagnosis. Second important thing is that where we should give prophylaxis. If our diagnosis is not so good, can we go for empiric therapy? Or we need only to wait for the targeted therapy? And if there is any therapy, which antifungal to choose? Shall we rely also on antifungal susceptibility testing? In case of the critical care patients, especially, where we need to look into the several host factors like renal hepatic failure, renal replacement therapy, patient's weight, hypoalbuminuria, if the patient is on ECMO, whether there is need of dosing alteration, whether we need to do therapeutic drug monitoring, and certain other issues like whether we should remove the central venous catheter if there is Candida sepsis. When we should do ophthalmic examination or we should do it routinely. Candida in lower respiratory tract or Candida in the urine, whether we should treat or not. Yeast in peritoneal fluid, whether we should treat or not. Few years back, we made this provocative statement. We said delivering on antimicrobial resistant agenda or antimicrobial stewardship will not be possible without improving fungal diagnostic capability. Because you don't know which drug to be given. There would be inappropriate use of antibacterial and antifungal, and there is possibility of development of antibacterial or antifungal resistance. At the same time, clinicians say, how I can wait for diagnosis? Because delay of starting therapy by few hours, there is increase in mortality. So there is tremendous high number of patients of unnecessary or inappropriate antifungal therapy. In several centers, it had shown more than 50%. Because the clinician like to start antifungal therapy before going to sleep. But at the same time, if you see our meta-analysis which we published last year, we showed that if you do diagnostic stewardship, de facto attributable mortality comes down, length of stay comes down, even the resistance comes down. So we need diagnosis. But when we say a prophylaxis, which patient group we should go for prophylaxis? At least in a cohort where the incidence is more than 10%. So if the patient is staying in ICU for a longer period of time with positive clinical predictive rule, or if there is recurrent GI perforation, recurrent peritonitis, or if there is acute necrotizing pancreatitis. Now, as the diagnosis is not coming so successful, IDSA has recommended that go for empiric therapy if the patient is not responding to antibiotic and if there is risk factor like Candida colonization, severity of the illness, all these factors are being there. And if the patient is unstable, go for echinocandid. If the patient is stable, go for fluconazole. But at the same time, this empirical study, which we had shown that whether you start empiric therapy or not, there is no difference in case of survival of the patient. So I prefer this. I think about this particular ECMED, the critical care group says that if you have this risk factor, look into also the biomarker. Biomarker can help. Even if you have started antifungal, if the biomarker comes negative, you can stop the therapy. On the other hand, in case of candidemia, there are several scores are there which you can try, but at least in India, we found it is not so successful because in India, patients, 95% of them, in case of ICU, they are already colonized with Candida. So no colonization index can help in this scenario. So possibly we need to use this biomarker for this. So whether it is in empiric therapy or in targeted therapy, which drug to prefer? It is usually said go for fungicidal drug where there is echinocandin or amphotericin B. And several of these trials had shown that yes, the echinocandin or this liposomal amphotericin B is better. So first go for echinocandin. If for any reason you cannot go, then go for this alternate liposomal amphotericin B. Next question is, does species matter? If you look into all these species, preferred initial therapy is echinocandin. But for alternate therapy or step-down therapy, possibly you have to look for the species. Like suppose in Candida glabrata cruzii, you cannot use fluconazole. Possibly here it is the voriconazole which is important. I like to stress to this Candida auris issue because here it is susceptibility dependent. Here we are now concerned about Candida auris because this is particular species of Candida which is behaving like bacteria, developing resistance very fast, easily transmitted to 43 countries, multiple outbreaks reported. It is resilient to the disinfectant, contaminates the environment very fast and not easily identified. And in certain centers in India, it had shown that Candida auris is now first ranked in order of the isolates from bloodstream infection. And even in Candida, in case of COVID-19, there is a rise in incidence, and it has shown that even 42% of the bloodstream infection is because of Candida auris. So here, we need early diagnosis for the better outcome, and you can go for echinocandin, but do the performance of the susceptibility testing because we have seen in certain situations, even echinocandin is resistant. Now, we are also seeing several odd species. And in these odd species, we find that the fluconazole resistance is being there. Fluconazole susceptibility is very low in these cases. So here we need doing the susceptibility testing. That is very important. Now, it is not necessarily that isolation of Candida means in the blood means it is Candida. Sorry for the spelling mistake. And we go for echinocandin because there is non-Candida species in around 8% of the cases which have been shown. And it has shown that in these species, first line therapy is the liposomal amphotericin B, not the echinocandin. So these are the issues which we need to look into. How much we rely on antifungal susceptibility testing? At least in East, people used to rely on this. But now what it has been seen that usually we do the susceptibility testing with one colony. And it is believed that one strain producing the bloodstream infection. But recent data had shown even 5.6% of the blood culture isolate can harbor polyresistance. So here you have to take care when going for this. Biofilm issue. That is also very important to improve the outcome because in biofilm, increased drug sequestration is a big problem, upregulation of the drug efflux pump, immune evasion, and persistent cells, which we see in case of biofilm. So if you look into the susceptibility data, the planktonic phase and the biofilm phase, the susceptibility data is completely different. And here possibly the amphotericin B or the echinocandin, which might be useful rather than any of the azoles. Next question is, shall we take out the central line on? At least if you see IDSA guideline, it says remove the central line that is there. But the question in case of the neutropenic and thrombocytopenic patient, if there is any other access is there or not, that would be really important in case of deciding about it. Marcio Nucci and et al. Had shown that in non-neutropenic group, at least CBC removal did not affect the outcome. But other trials it had shown that other studies had shown that survival significantly better than CBC removal after CBC removal. So all this study looking into it, I suggest that without any randomized trial of early central venous catheter removal or retention versus retention, it is better you do the removal of the catheter. Otherwise, if you cannot remove, go for echinocandin or poly. Next question is, which organ is being involved? Especially in case of the brain and eye involvement, a lot of drugs may not able to reach, like liposomal amphotericin B. If you have to give very high dose, 10 milligram per kg. In case of the other azoles, especially in case of itraconazole, it is not well transmitted. It is good in case of voriconazole. We are not very sure about the posaconazole, but isavuconazole, it has shown at least in brain it reaches well. But in case of echinocandin, it does not go into this. Next issue comes in case of the critical care group where there is polypharmacy. Here you have to think about many issues. You have to think about drug interaction issue. You have to think about this patient condition. And this patient condition is so important. You can see that whether it is renal failure, hepatic failure, RRT or ECMO, here you have to think about that PKPD drug-based dosing may be required. In case of ECMO, it has seen that echinocandin is extracted out. Moreover, because of drug interaction issue, therapeutic drug monitoring is very essential. And generally we say in echinocandin, we don't go for therapeutic drug monitoring, but at least in case of overweight patient, you need to do this therapeutic drug monitoring. In case of amphotericin B, PK parameters are not elucidated well, so routine therapeutic drug monitoring is not desirable. Whereas in case of flucytosine or azole, we need this therapeutic drug monitoring. What happens if we have candida in respiratory tract or candida in the urine? In case of respiratory tract, whether it is from the sputum or it is a bronchoalveolar lavage, isolation of candida means colonization. Generally, you should not go for therapy on the basis of isolation of candida from the respiratory tract. Similarly, if you have candida isolation in urine, especially a patient who is already on indwelling catheter, it is strongly recommended you change the catheter. That would help. But in case of the high-risk patient, like neutropenic or infants less than 1500 grams, or if there is urologic manipulation which is being done, in that situation, possibly you have to give the drug. Like in neutropenic patient of very low birth weight, you have to give the echinocandin, whereas in case of the urologic manipulation, it is the oral fluconazole which would be useful, or amphotericin B deoxycholate. Next question comes, does all candidiac patient need ophthalmic examination? If you see the year-wise different study, the incidence of intraocular candidiasis is going down. Generally, we see these two pictures, one either Candida chorioretinitis or Candida endophthalmitis. Candida chorioretinitis is more common. It has been seen in case of 4 to 30% of the cases, whereas Candida endophthalmitis, which is more difficult to treat, is seen in 0.5 to 2% of the cases. Now, there are two types of opinion. IDSA and ICMate says that as ocular candidiasis rate is still 5 to 15%, you need to do routine examination. And in certain case of Candida chorioretinitis, there is no eye symptoms until unless you do routine eye examination, you will not pick it. Whereas the American Academy of Ophthalmology says the incidence is low and there is no change in therapy. Even if your diagnosis is Candida chorioretinitis, why go for this? If you have got endophthalmitis, then you have to go this vitrectomy, which may have many complications, and that is a different ballgame altogether. Echinocandin versus ocular candidiasis. Echinocandin is highly protein bound. It is a big size. So there is very small volume distribution in the eye. But when you see in choroid and retina, where it is highly vascularized, their echinocandin possibly can reach. But echinocandin concentrations are low in vitreous fluid following systemic dosing. So, post hoc analysis of prospective trial did not suggest increased ocular involvement in patients with candemia treated ideally with echinocandin. So, people still say that echinocandin might be considered for patients with asymptomatic candida chorioretinitis. And if frequent fundoscopy examination can be performed, then evaluate the progression and resolution till the resolution of the disease. Next question, if you do the fundoscopic examination when? Generally, people go for fundoscopic examination immediately after diagnosis of Candida sepsis or Candida isolation from the blood. Even 18 to 38% of the patient, it had shown that the diagnosis of candidemia, after 1 week, there is the ocular candidiasis may be present. So it is better to go for diagnosis in the second week. And how long therapy you should give? IDSA recommends 4 to 6 weeks because regular follow-up of fundoscopy examination are likely infeasible. Ideally, antifungal treatment should be continued until ocular lesion is completely resolved. So, availability of regular follow-up fundoscopy examination might individualize treatment courses in this patient. So, friends, summarizing all this discussion, what I like to tell you is that to improve the outcome, first think about, is it a Candida sepsis? Does the patient need antifungal? If you are going for this antifungal, does it cover the suspected fungi? It is not going blindly with echinocandin. Certain times in other species of or other yeast might be isolated where echinocandin may not work. Next question is it the first option recommended for the guideline? And whether your dosage is correct? And here, any chance of drug interaction? So, are you going for the therapeutic drug monitoring or not? Is the antifungal adjusted with the microbiological results when available? Is the intravenous switched to oral or de-escalated when possible? Is the duration of therapy correct according to the guideline? So all these factors, if you can take care, then there will be better success in case of the Candida sepsis. There are new antifungals which are coming up, of which I would say Ibex fungref, which have been already in the market against vulvovaginal candidiasis. Very soon it might be available for Candida sepsis. This particular drug, it had shown even in echinocandin resistant Candida species it was. Especially we are worried about Candida auris where it is coming resistant. So this is very important. Other than this, if we have reserfusin, at least this is very important because in case of echinocandin others, we have to give daily injection, whereas reserfusin once in a week. Manogojefix, that is another drug which is also possibly very useful. Thank you for your kind attention.